Ansel, you got it.
Okay. My name is Dr. Ansel Johnson. I am the Optic Medical Director for United EyeCOR Providers. So we are so excited to have our first EyeCOR Providers webinar. It's my job to bring good medical eye care to our members. And one of the very first things I thought about was EyeCOR. EyeCOR is a product I can personally tell you about, but we are very grateful for having Robert Rubella, who is the founder and CEO of NTN Software Limited, LLC, excuse me, to present a webinar we have this evening on hot topics in medical care. With optometrists and ophthalmologists throughout the country, and designed and developed numerous ophthalmic systems. Mr. Robel has been involved in medical records for well over 30 years and provides consulting for optometrists and ophthalmologists for proper medical coding and reimbursement. Also, the numerous COPE-approved seminars for the national stage, regional stage, and state levels, those associations, as well as most colleges of optometry. And these seminars include coding and reimbursement, compliance, ICD-10, and avoiding and surviving an audit. So it's a pleasure that, and one caveat, I have used the product for quite a few years, and that's why I can personally vouch and say that this is an opportunity for us to learn quite a bit about coding. So I'll present to you Mr. Robert Rubella.
Thank you. I assume that all of you Chicago area people are real sorry for me that I'm giving up watching the first Patriots game to do this lecture. I'm sure you're sympathetic about that. So, the purpose of the seminar, and by the way, this, and you saw from the previous screen, this is a COPE seminar. I've trimmed it down to get it into a webinar format. One of the reasons why I like to do this is because it is structured. The things I had to eliminate to keep it within a reasonable time frame, because where I can do a 2-hour lecture face-to-face, that's actually easy for the participants and myself, but doing on a webinar more than an hour is really tedious. So we're going to try to get through all these screens in that time frame. We're going to be talking about these areas. Get paid for what you're doing. One of the things that we see, and I just received an email from a doctor today, and his comment to me was that he just is not getting enough reimbursement and what he should do about it. So we talked to him about what I would do. But something I see all the time when I lecture, etc. So we want to really make sure we hit make sure you get paid for what you're doing. Also, related to that is the ICD-10 codes. We're going to talk about some of the expanded codes, new things that are coming in. There's a set of codes being implemented the first next month. Once again, every October 1st, they add ICD-10 codes. We're briefly about a HIPAA audit. They're much more frequent, much more severe, and done as a surprise, and we'll go into some of that. How to become a National Correct Coding Initiative compliant, and how to avoid and survive audits. Because again, of the case studies, I have far more usually, but I'm going to limit it to 2 case studies. All case studies that I use are actually from our users, and they were presented by these doctors at their various state meetings. So we're going to go through the first one. This one is a good example of when somebody's there for a routine visit and you find something medically wrong with the patient and what you do with that. So, and again, these are his slides. During a routine vision plan, the patient was in for a VSP exam. During that exam, found out the patient had high tensions and family history of glaucoma. So what doctor did is he finished the vision plan, the VSP exam, and then rescheduled that patient for a follow-on medical visit. We know that they don't always show up for that. So I'm going to also discuss some of the options so you can get as much done as possible at that first visit and not depending on coming back. He said, first of all, is he billed the exam as a 99213. He did all the history, including history of present illness, history, review of systems, did all the exam element levels that he was required to for that level 3 exam, assessed the patient risk, and he said, what else? And showed what the EyeCOR screen does. It was showing you all the different procedures you can do for that diagnosis. In this case, it's low risk or borderline finding, so glaucoma suspect, bilateral, and showing all the procedures that he could do. From that, this is what he ended up billing. And when he did this, he actually went through all the procedures. So he billed the level 3 office visit for the follow-up visit, which was medical tied to the glaucoma suspect. And he finally did funded photos, scanning laser, gonio, visual fields extended, pachymetry, and serial tonometry. I normally would ask for a show of hands. Does anybody see anything wrong? And that funded photo and scanning laser are, in fact, mutually exclusive. So what he actually did was he performed and notice the date of service on the left. He performed the exam and all the procedures on day 1 and had the patient return for the OCT, and it billed with the same bill, all on the same claim, but it shows a different date of service, which is legitimate, so he got paid for everything. So it's important to understand what's going on here. If with one diagnosis he had billed both fundus and photos and scanning laser, he wasn't denied on the fundus photo because it reimburses higher. So this way he avoids losing reimbursement. And look at the total reimbursement, because there's a lot of stuff that you can form for different diagnoses that many doctors are not aware of. Then I'm going to ask for questions at the end of these case studies. You do have the chat feature, so do the chat, type in anything, and they'll be monitored, and then when I ask for questions, I'll be giving those questions. Foreign body, I have caught because this is something that's very important. A lot of doctors lose significant amount of reimbursement about the way they handle corneal foreign body. I actually gave this at the National Glaucoma Society meeting, and all the doctors were objecting, saying they started yelling about, why am I doing corneal foreign body? It's a glaucoma meeting. And I said, let's just go through it. And they were afterwards extremely happy that they did. Different doctor, he goes through with the diagnosis, corneal foreign body. It was a new patient, so he did a 99203. Eye pain for the chief complaint, pain for the past 4 hours, etc., and all this other stuff, what he did. End of his lecture, because I was at this lecture, I asked him if he actually got paid for the exam. And he said, of course he did. Well, he went back to his practice the next week, ended up just going through the process and finding out, and he called me back the next Monday, and he said, you're right, he didn't get paid for it, and they checked multiple laws. And that is, most payers, corneal foreign body removal does not support an exam. In other words, the removal of that foreign body is the entire exam. That's all you get paid for. However, you notice what one of the HPI chief complaints are. Eye pain. It hurts with the foreign body or blurred vision depending on the location of the foreign body. Then what happens is you can add the eye pain diagnosis code, and I get both because he actually did this when it was ICD-9. I added the ICD-10 codes, and using that second diagnosis to support the eye pain, supporting the exam. Excuse me. So let's look at some of the stuff that you can do. And this is where it really changes what you do. First two are corneal foreign body removal with and without slit lamp. And it absolutely make sure you realize you should be doing it with slit lamp. There is no difference between the actual procedures except you look at the foreign body with the slit lamp versus without. It reimburses across the country approximately $10 more than without slit lamp. One of the things that I would strongly recommend also is check your EHR and or practice management system. Unfortunately, we see many of them with only the CPT code 65220. So even if you did it with the slit lamp and use that 6520 code, you can get the full reimbursement. So make sure you have 65222. We actually say on cheat sheets, whatever you want to call it, that's the only one that should be there. The next one, and I'll ask for a show of hands at this point. How many, if the cornea is damaged and you want to use an algebrush to clean it up, it happens frequently. Then I ask how many people do it. I see almost every hand. Then I ask how many people are billing for it, and almost all the hands go down. With or without cauterization, it reimburses higher than the corneal foreign body itself, the removal itself. Make sure you have this in your list of procedures if that's what you're doing. They're serious enough that you want to add a bandage contact lens, then you can also charge for the fitting. So here we'll look at actually what was billed. The corneal foreign body removal with slit lamp at $83.53, the removal of the corneal epithelium, the bandage contact lens, and the exam. And that's everything there. Whether you use a 992 E&M exam or a 9.2 ophthalmic exam for medical for this thing, neither one, you need to use a 25 modifier. The reason for the 25 modifier is you've performed a surgical procedure, i.e. any procedure starting with the number 6. At the same time, you're billing an exam to a different diagnosis, eye pain, so you have to use the 25 modifier in order for that to get paid. The interesting thing is here, what you're looking at, if it was bilateral, now you can bill the 65222 for right and left eye. You can bill the removal of corneal epithelium for both, as well as the bandage contact lens. So that you really have a significant increase if it becomes a bilateral condition. One thing I'm always asked about is what if there's more than one foreign body in an eye? It is per eye, not per foreign body. So whether there's 1 or 10 foreign bodies in an eye, you only bill that one time. One reason I left this one in, actually added this one, is dry eye, because there are a lot of procedures that you can perform for dry eye. As you know, it is a very common problem. There are significant procedures you can perform for dry eye. Questions?
At this point.
All right. Still from anybody?
If any questions, please just go ahead and type them in the chat section, the bottom right. Those questions in at any time, and go through questions. We'll read them off for Bob.
Okay. So medications is another thing that we really harp upon for increasing reimbursement and for something that's going to help the patient. If you can, whether it's a medical patient that you have or if it's simply a wellness exam patient, make sure that your pre-test staff are recording a systemic medication. We see that process skipped a lot where practices only record the ophthalmic medications. Make sure you check the systemic meds. The reason why is, and we have this in EyeCOR, you look up a systemic med, it will tell you what the ocular side effects of that medication are. So, for example, if somebody's on hydrocortisone or whatever the high-risk medication is, you look for the side effects. We have both the common ocular side effects and the severe ocular side effects. The side effects are determined by the FDA and the manufacturer of the medication. We get information from the drug manufacturer. So if a patient has one of these, or you notice something from the fact that they're on this medication, now you can flip that to a medical patient for increased reimbursement. Now, the other thing is, even if the patient is not experiencing any of these side effects, the fact that this is a high-risk med, it has severe ocular side effects, you can then, down at the bottom of the screen, click on that red button, and it will show you all the diagnosis, all the procedures that you can perform just because the patient is on this high-risk medication. There is a specific diagnosis code at Z79.899. It is high-risk medications is there, it's available. The way you build that is you build the primary diagnosis as their systemic diagnosis, the systemic condition. You have to be, for example, if somebody has body function that's not, you don't have to get very specific. You can be very generalized on that. So, for example, rheumatoid arthritis, you don't have to get into what part of the body it's in. The second diagnosis is the Z79.899. All procedures you perform must then be billed to that second diagnosis. So on that line, it would be B for pointing to that second diagnosis. This is something, the reason why the payers pay it is because you are using your instrumentation for the fact that the patient is on or taking these high-risk medications, and through that, the different procedures that you perform, you can then detect a condition developing at a much earlier stage. So that's why the payers are doing it. So it's really the benefit of the patient to be able to, for better clinical outcomes. It's also better for you, the doctors, because it's a significant increase in reimbursement. And so here we got, for an example, well, we show billing fundus photography, visual fields, and an ophthalmic exam for the total insurance bill for $302. It works. It's something that it is very, very important to do because it's a significant increase in reimbursement. If a patient is there and you want to just do this, and they're there for a VSP or EyeMed or Davis Vision exam, whatever, you still bill the VSP exam to their VSP account or whatever. You bill the refraction to them. Then medically, you can bill the fundus photography, the visual field, whatever procedures you do to their medical insurance. Because you bill VSP for the exam and it's on the same day, now you cannot bill the exam medically. But if they return for an additional time, then you can bill the procedures and the exam. One of the things that I frequently hear after my lectures is, that's not true, you can't do it, you're going to get hit. We do audits around the country for different clients to make sure they're doing compliant coding. When we're looking at the EOB processing for this particular client, we've seen multiple since then. They're at one of my lectures and they started billing this. This is EOB showing, and they billed it for that high-risk med code, and they got reimbursed for an exam, of field, and fundus photography for a total actual pay reimbursement for $179. What are the types that you should use? Always said it really doesn't matter whether you use a 92 ophthalmic exam or a 99-200, and I'm talking about for medical reasons. Clearly, EyeMed, etc., wants a 92 for their wellness exams. Remember, it started as an ophthalmic medical exam. It is also still and should be used in many cases for billing medical exams to their patients. What happens is with audits, we've been seeing the EHR systems do not have all the required components for a compliant evaluation and management exam, the 99-200. Specifically, many of the EHR systems are missing completely medical decision-making, which has three components. We do this continuously. We just did 2 audits within the last couple of weeks. Did 2 different practices, 2 different systems. Neither one of them had medical decision-making. One of the doctors, and we have had many, but one doctor called us back a couple of years ago, and she was hit by Blue Cross, and she only used 99-200, and she was hit with $195,000 in penalties. They told her none of her 99 E&M exams, and that's all she used for billing, were compliant, because they specifically cited the EHR system. So we had to try to help bail her out of that, which we were to some degree. But it's one of the things we see. Many EHRs do not have a compliant coding or documentation for evaluation and management exams. So one of the things we recommend, when possible, to to go back to using for medical the ophthalmic exam. One of the things, if you look at equivalency, that are actually reimbursed higher than some of the 99 exams. So if you look at the bottom one on the right, the 99213 for an established patient, which is a usual starting point, but if I go to the 92012, that still reimburses higher. So you actually have significantly less documentation requirements and extremely much higher reimbursement. There's a lot of reasons to make sure that you evaluate that. And unfortunately, we find most EHR systems, and it's one of the reasons, and I'll talk about it later with the exams, what's going on and what they're showing for reimbursement, and so that you can do actually better with the 92 exams. Right.
Yeah.
Or a couple pop up.
No, it's me sending questions. Actually, a notice to Michelle Santucci. Dr. Santucci is signed on, but she's not listening in on the...
No, I actually saw somebody asked me, Ansel Johnson raised his hand. Why don't you, Ansel, unmute yourself and ask it. Yeah.
I was muted.
Yeah. Yeah.
Yeah. Looking at the 99214 codes, I wasn't there, so I use those quite often because when I understand if you have multiple diagnoses, like 3 or more, they will qualify you.
Yeah, it does. It qualifies for a 4 on that part, no question. The issue is it also requires a higher level on the medical decision-making component. So if you don't have medical decision-making, and go into that right now. Medical decision-making. This is what's missing from most EHR systems. Amount of complexity data review. This is what you have to, or the EHR system has to document, and this is what's required by the payers. So, for example, under that, diagnostic service plan, you review that procedure. You obtained all records, and you obtained relevant findings from all records. I don't even have to go. That gives you 4. The problem is, most EHR systems are not recording that. You only need 3, but if it's not in your exam documentation, you will fail an audit. Pay risk, one of the most popular systems in terms of number of users, actually does record, or allows you to enter patient risk. However, it doesn't save it. So when you print out the exam for an audit or a records request, it's not there. That's why some of these systems are losing an audit. If you can actually see the specific information of those, at least 2 of those 3 categories, you bill it based on complexity, but you're going to lose in an audit, and we see it constantly. So that's where we're warning you. Okay. Let's ask a question. Why don't you just unmute yourself and ask? So I'll hold off on that question about how frequent they audit when we get to the audit section. Unmute yourself and say it. Okay. Mutually exclusive procedures. Just a short amount of time here. Funded photography and all forms of scanning laser, OCT, GDX, and HRT. Those are the only 2 anymore that are mutually exclusive. Right. 3 scenarios. I skipped the screen. Excuse me. With single diagnosis, you can only bill 1 mutually exclusive procedure on that day. If you bill both fundus and OCT, it will always deny the fundus because it reimburses higher. They want to save their money, the payers, and will only pay the OCT. So you're going to lose that approximately $70, $80. You can come back, which was the first case study, and so you do it that way. The third scenario is, let's assume the patient has glaucoma. In addition, some unrelated retinal issue. Now, because of two different diagnoses, you can now build both fundus photography and an OCT retinal scan for an example. You know that in this scenario, the fundus photo is pointed to the glaucoma diagnosis, and the retinal OCT scan is pointed to the retinal diagnosis. You can do both on the same day because they're pointed to the same diagnosis code. Note on the bottom line, avoiding using the 59 modifier. Previously, and some practices are still doing this, you have to use the 59 modifier on the fundus photo in order to get paid. So in other words, you bill both procedures, you bill them to the appropriate different diagnoses, and you put a 59 on the fundus photo. However, a couple years ago, CMS came out with a report that said the 59 modifier was the most used and abused modifier. And as a result, they were going to look at all claims with the 59 modifier a second time. The last thing you need is CMS looking at your claims again. So what we recommend, because it's the appropriate replacement, is the XU modifier on the fundus photo. Stop using the 59. I don't want CMS or anybody looking at your claims an additional time just because of that. So here we're showing mutually exclusive. We really show them in EyeCOR in yellow at the top so you know exactly what is mutually exclusive. Interpretation report. We're still seeing most practices fail an interpretation report audit or an exam audit where they're looking at the interpretation report. Many systems have, in their EHR have some kind of reporting mechanism. The problem is, again, many of them are not compliant. One of the we see is, and most, when we say 80% of optometrists and ophthalmologists are not doing them or not properly, actually, most of them are not doing them properly. You need to make sure that you're doing them. When a procedure says it requires an interpretation report, it really requires it. It's not optional. You have to do it. This is a list of the procedures that require an interpretation and report. What in EyeCOR is we have it, and the reason why I want to show you this is are the three categories. You must record clinical findings, which is what did you do, what did you see? Comparative data, change in condition. For diagnosis that you're performing this procedure, is the patient's condition better, worse, or stable? And then finally, clinical management. You must record all three of those. If this is the first time you're performing this procedure for the patient, then in comparative data, change in condition, you can simply say initial visit or just the first photo. But you have to have something there. Even if it is the first one and it's blank, the auditors will deny it. So you need to make sure you have all three. One of the things we see in most of the EHR systems that have reporting facilities in them, they only really ask you to do the clinical findings. They don't talk about change in condition. They don't talk about clinical management. And that's where using an IR in an EHR system that doesn't have all three is consistently failing an audit. And so you have to be very careful. Many of the systems don't have it, so you actually have to manual type condition. Optic cupping is increased and scheduling the patient back for 3 months, whatever it is. But you have to have something in that, even if you're just doing it in your EHR system. What document? This is another thing that we see, and this is it's actually built in to the EHR system. And I highlighted in red. Follow trend analysis. Directed treatment is indicated in plan. One, you can't refer in an interpretation report. Everything has to be included in that report. You can't refer to something else, even if it's in the EHR system. Second, it's canned. It doesn't really say what you're doing, what your plan is, what the clinical management is, follow trend analysis. And we have seen this get hit multiple times. We've contacted the EHR vendor to tell them to take it out because it doesn't pass muster, but it's still in there for most of those systems. So be very careful. Make sure you have all three components. Again, I guess Bob's not seeing the question, so if anybody has questions, just unmute and ask. Nope? Okay. ICD-10. Well, it's 2 years ago. It's been implemented. Last year they had the expanded ICD-10 codes, which was a major change to the original ICD-10. They also eliminated unspecified codes. Next month, and we've already have these in EyeCOR, we'll release the actual showing of them so you don't use them wrong right October 1st. But there's a whole slew of new codes, new ICD-10 codes. The big thing is, and we still see this, unspecified codes. Most EHR systems have unspecified eyes. So it'd be your pre-open angle glaucoma, right eye, left eye, bilateral and unspecified eye, problems, unspecified lid. If you have an unspecified eye or lid, it will be denied. One thing, unfortunately, some payers are doing is they're paying it initially, but then later going back and having them fail, and then you have to return the reimbursement plus interest and penalties. You need to make sure about your billing people are not letting these unspecified eye, lid, etc. codes. If you have a specific condition is unspecified in some medical systemic condition, it's the only code, then that's all right because it's an unspecified condition, but you cannot use unspecified eye, lid, etc. That's absolutely cannot do it. And it will be denied or they'll get you later on. About all this. Yeah, again, for the first year, they allow the unspecified codes, but after that, they said you have to stop. So as of October 1st last year, that grace period is over. You need to make sure. The people, we still, every once in a while, get a call from a billing person, still wondering why their procedures and their exams are being denied. And we find out when we look at the EOBs and the claims, they're still using unspecified diagnosis codes. It will be denied. One of the things I talk frequently is when we talk with the billing person, whether it's in our audit or they're calling us for help or whatever, or the doctor asks us to talk to the billing people, and the billing person will come back with something. I've been doing billing for 10, 15, 20, whatever the year time frame is. The problem with them is that typically that's exactly what they do, and they're still doing it the way they did 10, 15, 20 years ago. And as everybody else knows, things have changed tremendously, and so you have to make sure. That's one of the things with the EyeCOR, that you'll actually be able to, exactly when something's changed, something new, and we specifically tell you about it in the program, as well as if it's very specific and major things, we actually email all our users with what the changes incur.
I have a question.
Sure.
What about unspecified codes? Let's look at something as vague as visual field defect. Specified. Is there an unspecified code?
That's okay, because it is here. Let's go back.
Because small defect is not a hemianopsia.
That's perfect. That is perfectly legitimate. Let's see, they use other.
Well, just a visual field defect.
There's no unspecified. Here it is, right here, very first one. That actually falls in under the diabetes codes, so it's not really for that. But if you have, again, other and is for defect, that's okay, or in this case at the bottom is other or unspecified. There's nothing wrong with that. What you don't want is unspecified eye. Okay?
Okay. The vision code, I always kind of code with vision plans. It's pretty easy. Propia does not specify an eye.
That's easy. That makes it easy. Now, until they change that.
Yeah, anybody myopic on only one eye.
POG was originally one ICD-9 code, then it came up to 5, now it's 20. And again, you should see this already. You should be familiar with POAG, right eye, left eye, bilateral. I have eliminated all the unspecified eyes with the severity. One of the things I'm frequently asked, the reason I showed this slide, stage, mild, moderate, and severe. It is not something that's objective. It is very specifically defined. ICD-9, then they added those severity codes to go with the glaucoma codes. Came out with very specific definition of mild, moderate, and advanced to severe glaucoma damage. That is from CMS. That is how you define or use the actual definition for mild, moderate, and advanced to severe codes. The others actually use this. So if you code one thing and if it's defined something different, they will deny those diagnoses and therefore those procedures. So be very careful that you're using the proper definition for the severity. Is it done differently than the medical? If you're into this, have already been doing this, the S&T codes, foreign body as a T code, and the way they do that in very little time. Again, we're not showing unspecified. Foreign body in cornea right eye initial, there's your code. If you come back and the foreign body is still in there, someone who was undiscovered or something, then you would code the subsequent. However, if all the foreign body or all the foreign bodies were removed on the first visit, then what you do is you're going to have corneal abrasion. So you have the corneal abrasion in right eye or left eye. Now, there is no procedure, a diagnosis code for just corneal abrasion. It is combined with conjunctiva. So just as you understand that, but that's the sequence you would be using. These codes. This is just, and it's replicated identically for type 2. 1, 2, 3 screens for diabetes. Very, very complicated. You have to be very careful what you're using. One things that we do see fairly frequently, some of the people using with complications. If there are no complications, that's fine. But if there are ophthalmic, you should really be defining those because you want to make sure that you get as specific as possible. Bottom line, stop using unspecified eye, lid, etc. codes. Any now?
On the disease, a lot of times you have diabetes with diabetic cataract.
It is right there.
Right. Someone has had the cataracts removed, pseudophakic now. Can you still use that diabetic cataract?
There is no. Yeah, that's a good question. There is no pseudophakic code. I would probably say you could use that, or using one that's the with ophthalmic manifestation, something like that. Problem with that, yeah. Why say they go to get you? It's interesting what they're doing. First of all, if you have a sign-in sheet and it shows all the names of the patients that signed in before that next patient, and HIPAA auditor comes in, you will lose the HIPAA audit immediately, instantaneously. It's over with. You can use the ones with the tear-off strips or have what we recommend. If you really need a sign-in sheet, have the front desk staff control it. Just fill it out themselves. Don't give a sheet with other people's name to the patient. I still have not heard any practice tell me why they really need it. And we do audits, and that's what the first thing we look for when we do a HIPAA audit as part of our regular full audits. And the first thing I look for is sign-in sheets. And if they're there, we always ask, do you really need them? And, oh, yeah, we've always had them. Well, what are you using them for? Well, we throw them away. Well, you don't really need them. But still, if you feel you need them, have the receptionist control it. Questions with patients are about patients. One of the things, and again, it's something we actually want to do our audits while the practice is running. In other words, the doctors don't have to stop practicing. We actually want to see that. One of the things we see frequently is the doctor is escorting the patient back to the front desk discussing a medical issue. That is a HIPAA violation. You cannot do that. If on that walk back, whether it's you or a pretest person or somebody else, and the patient asks a question in public, you have to stop them immediately and just say something like, for patient confidentiality, let's go back to the exam room and we'll answer all your questions. You not do it. If somebody's walking or you're walking a patient back and it's something about their glasses or frames, stuff like that, no problem. But if it's a medical issue, you cannot discuss it. And computers. Scenario is pretest staff does something with that patient first in a separate area, then brings it into the exam lane or leaves them in the pretest area or brings them to the exam lane. If at any point the patient is in with the computer alone, in other words, left in the pretest lane or brought into the exam lane and the doctor's not there yet, every time you leave that computer, you have to log out of the EHR system. You don't have to kill Windows or whatever you're running, but definitely have to get out. I talked about this, and I've had many doctors say they've walked in or the pretest person went to escort them, and the patient's on the computer looking up records and stuff like that. That's a HIPAA violation, so make sure you do that. Skilled exams. This is the best one. A couple of years ago, I had a doctor who did not use pretest staff. And two patients scheduled an exam. New patient came into the exam lane or was escorted into the exam lane with somebody else. Just before the doctor started the examination process, he then thought about it and asked the patient, was it all right for that other person to be in the exam room with him? The patient then said, congratulations, you just passed a HIPAA audit. They actually scheduled an exam, and no, they didn't pay for it, and that just to catch it. So now if you have pretest staff, and this is we really harp with the pretest people, because if they're the first ones, and they start asking questions without asking that other person that's in that exam lane or the press area, you've just lost the HIPAA audit. You have to make sure that your pretest staff, if they're the first one, if not 100% sure that the person with that patient is the patient's spouse, child, parent, etc., but they know who that is, that's fine. But if they don't know who it is, they have to ask. One mistake can hit you very, very deeply financially. It's something that, CMS has had these HIPAA auditors going around, and the scheduled exam, it's sneaky, but they're doing it. So be very careful. HIPAA requirements in the bottom line is a couple of years ago when they changed the requirement, it was then changed to the patient only has to sign the HIPAA form once in their lifetime. It could be every visit or every year. Now it's once in their lifetime until it changes again. But currently, you only have to have them sign it once.
What if your HIPAA policies change a little, or the office makes a slight HIPAA to sign that new form again?
It's compliant. The problem with the HIPAA form is there really isn't a standard one. Previously, CMS had a standard one. When they changed the requirements, they changed it, and we actually refer people to either look at what a hospital or a very large clinic has to do for a HIPAA sign-in sheet. But if the changes were significant, yes, I would do it just as a CYA. This would say, with PQRS and meaningful use, so many of the EHR systems failed meaningful use miserably. They also did not, even through claims or whatever, did not do PQRS properly. I've gotten hundreds of phone calls from practices, and when I lecture, I hear it all the time. Telling me, a doctor telling me, we went and submitted PQRS all of last year or the year before. We failed on one measure or one thing only, and we failed and were penalized. The issue is that if you fail on that single one, you get the same penalty as somebody who didn't even bother with submitting PQRs at all. So we just said, don't worry about it. The penalties are low. But MIPS, they're now talking about getting very serious and penalties going up to 9% a number of years. So the thing is now, you do the PQRS. If you failed with meaningful use through your EHR system, you need to get on them to straighten it out. But PQRS, start doing it. Because even if you fail, it's did now and it's on a percentage basis, not pass or fail. So previously, you failed one thing, you lost it all. Now they're looking at percentages, and we see people who failed were 95%. Now with the current standards, that actually would be considered that 95% is a pass. So start doing it to get used to it this year, so you get better and better and better at it. Do it through your claims. One of the problems we see is if you do it through your HR system, most of them screw it up. So do it through your claims, and you really start doing it. It is a combination of how much you bill Medicare. That's not in place yet, but it will be. And the interesting thing, it's really what MIPS is all about. The only way you can score higher on that category is guess what? You bill Medicare less than what you have in the past. Ridiculous, but that's what it is. PQRS, meaningful use, in the value-based modifier. So we're saying right now, focus on the PQRS, get used to that, and then get your EHR system to get meaningful use correctly done. I'm not saying that we already talked about this. I just said all this. Any questions before I go any further on the audits? Anything?
I have a question. What's the cost? What's you seen high and low if you fail a HIPAA audit?
They're over the place. The HIPAA audit has been between $50,000, $60,000, $70,000. Serious. And by the way, I didn't have it in there. Remember one thing. If they're not doing a heck of a lot, make sure you assign somebody as your HIPAA person on your practice. That's one of the things they look at. Okay. Now, audits. One, I hear this all the time. Doctors tell me it scared the blank out of them. I have doctors telling me it's not true. I have all this other stuff. Then afterwards, especially frequently hear from doctors. I actually did a lecture in LA last January, and one doctors who I know went up and said, "Oh, your sky's falling, the sky's falling, be very serious." And the rest of the doctors around said, "I guess he wasn't paying attention." A doctor who absolutely reamed me in an email after a lecture saying it was absolutely not true, skeptics, absolutely a bunch of bull. I got a phone call from him. He told me who he was, what about the email and everything else. He did and hit $450,000. Fortunately, I didn't believe you. Now what do you need to do to help me? The problem, after you get hit, there's some things we can do, but most of it's too late. But this is very serious. All the payers have increased their auditors, increased their audits. I honestly don't know if I had this slide, but last year, Office of Inspector General went to Congress, got it passed, so it was in effect, about allocating $100 million to CMS just to hire additional auditors. Everybody is getting serious about that. The average penalty that we see, first of all, when they audit you, they actually have the claims in their possession. You've submitted them to them. So they look at your claims. They actually go through your claims and determine what they feel is suspicious. They don't just randomly look at claims. They actually look for a suspicious set of claims. Now they come in and they say, or they email you or send you a letter saying, we want 40, 50, whatever the number of claims is. You send us the claim, the exam documentation. because they're very specifically selected, the failure rate, and this is the auditors confirm this with me, is over 90% of the claim or the exams reviewed fail an audit. It's very, very serious. So you have to be careful. How they select you, it's random. If they ask for a documentation, a lot of times they'll say, well, I want to see this X number of records. It's usually a low number of records. If you don't get them to them, or if there's something suspicious about them, that could trigger an audit. Billing in excess of the regional norm is, except for VSP, we never see that. It's just not one of the things that we see as a justification for an audit. Average penalty, a couple of years ago, went between $100,000 and $200,000. And last year, we have never seen a penalty for less than $150,000. This is how serious it is. That is for solo practitioner practice. One of the things that when I've talked to the auditors, I've actually lectured CMS auditors. And one of the things that they, and the auditors that I deal with, Blue Cross auditors, ESP auditors, Medicare auditors, Medicaid auditors, is really find fraud, especially in an optometry scenario. They do find non-compliant exam documentation with EHR systems. Many of them told us they see the templates or the printouts, and they know they're going to make money because they don't have everything that's required. One of the things we also see, which is really unfortunate, and this is fairly frequent, come into your practice and look at your records. They don't go on your computers. They're not allowed to. They have you print out your exam documentation and send it to them. In the case of VSP, they come in, they want X number of records printed out right then, and they want to walk away with them. The problem with some EHR systems is they print everything that's in the actual exam itself. The real problem, because we see practices fail audits only because the print reports don't show everything that's in the exam. So as you tell people, and I'm saying it now, do out of your exam. Compare it. Make sure everything that's in your exam is actually in the printout. If not, contact your vendor. The audits, I'm going to caution you here. Whereas they come in unannounced, no notice whatsoever, unlike all the other payers. They tell you only the following. I want all documentation related to these patients. They say all documentation. What happens is, and if you ask them about the claim, no, we already have that. We already have the EOB. All right. So now your assumption is they want the exam printouts. In fact, most of their audits, what they're looking for is proof that you actually dispense the lens, the frame, the contact lenses to the patient. That's not on your exam. We constantly deal with VSP audits where they fail, and then they call us, and it's always the exact same scenario. Every single exam, every claim is denied 100%, and they have these huge penalties, hundreds of thousands of dollars, and you look at it, no proof of the materials dispensed. Well, all they had to do, and the auditors do not say, make sure you include what that whether it's your prescription form or your order form, whatever. And we recommend that when somebody comes in to pick up glasses or frames or the contact lenses, that form where you have the prescription for the optical, have the patient sign it that they picked up that stuff. Those things or scan them into your system, but don't throw them away. That's what you need to make sure you get, and you'll be much better off with a VSP audit. With an ophthalmologist who had been hit actually multiple times by different payers, and in each case he was hit for over $200,000. And his complaint was all they found was $20,000 of exams, etc. And how did that become $200,000? And that's because every payer extrapolates. I said they have a set of records, say approximately 40, and they base it on that and say you have a 90 to 95% failure rate. They take that rate and apply it to all your reimbursement for them for the last 3 or 5 years, depending on the payer. This is an actual thing that we had that I recorded from one practice that got hit. So, we had records reviewed was 45, and remember I said 40 to 50. Rec failed there, this is the exam documentation, failed was 41, so 91% failure rate. Now, total reimbursement was $127,000. Percent of fail is $116,000. Interest and penalties was $79,000. As a result, the total by the practice was $195,000. What they do, and every payer does it. Some of the stuff on what we find gets caught. Diagnosis. Sure that the diagnosis code supports the procedures, the exams for medical, etc. One of those, we had somebody get hit. They always put refractive diagnoses first, and the biller always promoted everything to A. In this case, Blue Cross paid it. Then they came back and hit them for serious money. Make sure that, the reason why I say make sure the auditor knows the codes, we actually had to bail out or help a practice that got hit in a Blue Cross audit. And when we looked at the records, they got hit for $195,000. We looked at the documentation. Everything was fine. No problem. What the auditor said was that the diagnosis didn't justify the exam level or the procedures that were built. We actually had called for an appeal hearing. The doctor's wife was the practice direct manager. The doctor and myself went to the hearing. The auditor from Blue Cross was there, plus her supervisor. We went through certain things about that he wasn't doing right. And the bottom line was, I said, all right, you said that these diagnoses didn't support the exam and the procedures. And that's right. And I simply said, do you know what macular degeneration is? Because that was one of the two big ones. And she said, not really, but I know it has something to do with the eye. As stupid as it sounded, that was her answer. And said, well, the problem is if it's not treated, the patient will go blind. She looked at the supervisor looked at her, and they wiped out the whole $190,000. So that's why I make sure the auditor knows what's going on. Patient exam elements. Make sure you're doing what's required. Unfortunately, we see sometimes whether you're doing it or not, but it's not documented in the exam or it's not done, and you don't have the required number of exam elements. If you're doing paper, make sure you do all of them. Also, when you go through your list for the exterior and the slit lamp exam, and you have OD on one side, OS on another, in boxes or columns, whatever, don't draw a line through all of them for within normal limits. You will be denied by an auditor. As simple as it sounds, you need to check each element off. They will tell you you didn't really look at everything when you draw a vertical line. So that's a very simple way to protect yourself. Systems, make sure that you're doing it. Recall them. One of the things that we see, unfortunately, is the staff, the pretest staff, will ask the patient, all right, and they go through the list and they ask everything. And the patient will say, no, I'm all right on that. No, that's fine, that's fine. They leave those blank, the pre-people. If you leave blank, they don't count. Remember, within normal limits for a review of systems are no problem, it's a legitimate value. So you need to make sure you're checking off everything that's being asked. Bill a new 004 a 92014 for medical. You have to include initiation of diagnosis and treatment plan. It's actually fairly simple to do. It includes, so if you're doing a medical exam, does not happen for a VSP 92000 or Med or any of the others, but it does for medical. So, after that, you prescribed a medication, or new lenses, or a change in medication, or a change in lenses, or you did a fundus photo, or an OCT, or if it was a retinal issue, you did a referral. All those count. Just make sure you document one of those. Now you're clear. It's the number one reason for those exams being denied during an audit not having initiation, diagnosis, and treatment plan. So simply put one of those things in. It's very simple to do. Records. I'm drawing the line. Also, done audits for many practices. you still use paper records from multiple doctors. The number one problem is legibility. You need to make sure it can be read. Remember, the auditor wants copies. They're not going to be asking the doctor what was in there. It must be legible. Report, I already talked about the 3 categories. Make sure you document all 3. For a comprehensive exam, you have to do 3 history elements, and you should be doing that for every exam. And the 3 is not that I recorded 3 medical history or 3 medications or 3 social. It's 3, one for each of the 3. So whether I do 10 personal history items, that still counts as 1. Social history counts as 1. And family history counts as 1. Social history, you must record at least minimally alcohol and smoking. If the patient smokes, you are required, and this has been like this for a couple of years, that you actually discuss, or you have in the record that you discuss cessation of smoking. It is required if somebody is currently smoking. So those are things that you have to make sure. Family history has to be there. We see many practices don't record family history. If you do, not only does the condition need to be on the family history, but what the relationship is: mother, father, maternal grandmother, grandfather, etc., etc. Again, just this part is just to say this is where we see a lot of exams fail, and it's something you need to make sure your pretest people are doing properly. When we do an audit for a practice, we look at this very carefully. We actually meet with the pretest people on the second day after we've looked at the exam documentation to emphasize how important this is. Because if they're not doing the work properly and you do everything perfectly, you're still going to fail that audit. Oh, let me back up. It's been a couple of years. Height, weight, and BMI, they finally recognize that optometrists do not have to record that. So if you're doing it, and every time I do this with the pretest staff, they're all pleased because it's a problem, but it is no longer required for height, weight, BMI. Close records. All systems, the HR systems, actually allow you to pull stuff forward. If you pull forward, you need to make sure that you or your staff are making the changes. So if somebody's on a different med, make sure there. If somebody's on an additional diagnosis, make sure it's on there. Make sure the changes are there. Everything, in fact, is the same. What we can recommend, because if you're full forward and you don't change anything, the auditor simply will take the exam, look at a previous exam for the same patient, and everything for the history is identical. They say that's a cloned record, and they will fail all your records, so you have to be careful. So what we recommend that you have your pretest staff do is simply, if it is identical, just go into the meds, go into the the medical history, etc., and just add any one of the items, even if they're only blanks, and just say reviewed and today's exam date in it. That will show that it's been touched and done differently every time. The same will fail with the cloned record. The reason why is they are very strict on that is because it is for the benefit of the patient. Think about this. If you ask a patient, are you on the same meds you were last time? They're always going to say yes. But if you go through that list of, oh, I'm on this one now and I'm not taking that anymore. So make sure that you're doing it. It is something that's important to do. And just that simple thing will fail an audit. Making, I talked about this before. If your system doesn't have it and you're using 99, any other than a 1 or 2, you'll lose an audit. You have to be very careful about this. We people that are always asking about this after a lecture, you can contact myself or my staff and we can go through that in more detail. One of the things that we see some systems do, they claim they have it, they allow you to check or add one of those things which is showing, either the top one or the bottom one. The auditors will not accept this. You actually have to say what things you did to justify those levels. Remember I said, I reviewing the patient old records. I found something important out of that. I formed a procedure. I did an interpretation report. There's a count to 4. That's what they're looking for, not just a check mark or mild or moderate or whatever. All right, this complaint. Doing a 99 E&M exam, you have to also do HPI, and it's the location, severity, quality, etc. One of the things that's changed is you can now make that determination. You can document that. That's been like this for a while. Doctors don't seem to realize it. So in other words, if you find somebody with glaucoma suspect, you come up with the glaucoma, why, or both, how you determine it for severity, duration. Duration could be today. So in other words, you just found out, you just diagnosed it, and time is easy. It's continuous. That's a very simple one to do. So you can do that. Complaint. A patient sheet complaint, you can't bill it. We hear this all the time, and it's absolutely not true. So one of the things we say is, if you have a patient, when was the last time you had a patient that came in, sat down, and said, oh, by the way, I have primary open-angle glaucoma, and they've never been diagnosed? It doesn't happen. However, when's the last time a patient's getting out of the chair and makes some kind of a comment like, I'm on a plaque window, I have these flashes of light, something like that? The chief complaint, you can to get it extracted from the patient. It does not have to be something that they say initially. It is not the first thing they say. It's any point in the exam, and whether you extract that information by talking with them or they mention it later on the exam, and you can now proceed with that. Another on, real quickly, on when doing a procedure, you need to make sure you have an order in the exam. And it really has to say what, and I always do what, why, and when. I'm doing what procedure, fundus photo, why, for glaucoma, when, today, or next week, whatever. You need to make sure that you have that in your documentation. And if audited, if you didn't document it, as far as the auditor is concerned, you didn't do it. Again, just to go for severity, this is just a few examples. One that shows 2 on one line, that one practice that got hit twice. This is very serious. Talk about the paper records and make sure that you've done that correct. I can skip this. Real quickly, it is required for a medical 92004 and 14. It is required. A lot of people think because of what it says it often includes. The often is because there are some legitimate exceptions. Patient is too old, too young, medically contraindicated, they're going back, etc., for some critical job function, and they didn't do it. If you cannot use patient-denied dilation as a legitimate requirement for not doing dilation. You have to be careful about this. This is something that the payers are really looking at very carefully. A couple, you need to make sure, we actually had one of our staff members contact a local practice for a patient. She asked about dilation because she had to late, and they told they had a new instrument that replaced dilation. Fund photo does not replace dilation, not as any. It is still required dilation. Make sure that you also know what medication you've used. That's something that's required. I've already talked about all of this stuff. News is most we find are actually fairly easy to correct. When we go do an audit, we look at what's going on, we walk away, and before we leave, we sit down with the whole practice, explain what our findings are and recommendations. About a week later, we send them a final report. We verify they're making these changes based on our recommendations. The reason for that is so important because then we can say to them, okay, now your records documentation are compliant. Because most auditors, not all, but most auditors, if you say, okay, such and such a date you had an audit done by, and then on such and such a date we told you that you were compliant, most auditors will only go that far back, not look at older records. That's something that makes it beneficial to you. interpretation reports start immediately. Stop the cloning. Add something to the record to make sure it looks different from one exam to the other.
Bob, a question concerning if you just like yourself to do an audit, just to kind of protect yourself, and I think I might have said that already, and then you're audited, right? So it's all good to say that you have a system in place with that, even fail a few records or whatever.
If you follow, that's why I made the comment. If you follow recommendations, and we keep after you until, if you're doing an audit for you, until you get your records compliant. We keep after you until that happens. If you are there, then you're going to pass an audit. We've had people that have our audit and then were audited and passed. If you don't pass, then what we'll do is we'll look at the auditor's report, see what they found, and in those cases, we typically found the auditor was wrong. And so we work with you, we help you, we work with you on the appeal. So you're having an audit done and making sure you understand that you were certified, then that helps tremendously.
Okay.
Most medical insurance auditors are fair. You can, and because they're looking to have you change, one of the things, so you need to make sure that you actually make the change. If you wait until it's too late, now you're in trouble. And then I see, again, they ignore, and then later on they call us and say, we have some real problems. You need to make sure. Make doing it. So, medical for significant increase in reimbursement, testing and checking your systemic meds for wellness patients for ocular problems, evaluate. This old, I've just realized that. Significant increase in audits, so you need to protect your practice. Bottom line is, in terms of the medical coding and reimbursement to increase it, that's one of the things, as Ansel said about EyeCOR, it works. It has a significant effect on increased reimbursement. We're going to show you everything you can do for a diagnosis. We're going to show you all the diagnosis support procedure. We have to use your current fees for your region. So, and we see so many times where practices are not billing their usual customary fees are low, you're losing money. So there's a lot of stuff that we can do for you. And if the other questions, I think I'm done. That's my email address. I'm actually traveling all of next week. We're doing 2 audits simultaneously next week, and then I'm gone. I'll be out of the country for 2 weeks after that. But you can if you have questions over the next couple of days, you can get in touch with me. If not, you can contact the office. Any further questions?
I want to thank you very much, Bob. It's just a kickoff to our webinars, and I mean, I couldn't think of starting it any better. But right now, if he's still in line, I want to pass this on to Rick Peterson, who is our United EyeCare Provider President, and whose vision is really we're just trying to follow and keep up with him. So Rick is on the line. Just a few words and how EyeCOR and United Care are partnering to help our members.
Every single presentation that I go to, you take away something, and I think this is an important step in not only the webinars, but giving us tools to be more effective in our practices. And I think not only tonight, but every time we use this presentation in the near future, I think it's getting more and more of our members to recognize the importance of the guidelines. And even though I think I'm doing things great, and I'm always making changes, I think each one of us needs to look at certain things. And having that final summary and checklist, I actually took a little picture of it just to know this is going to be my checklist for what we're going to be doing. So this has been an outstanding presentation. This is great information. And key, as we always say, go back to your practice, do 2 things tomorrow, because if you don't, you're going to forget it.
All right. I'll also say, because this is a video presentation, it's going to be on your website, but if any of the attendees want to actually get copies of the slides, you can email me or email the office, and we'll send you those slides.
Thank you. Wonderful.
Okay? All right, and then I think with that,
I will say tell our members view this presentation to keep it, because we're going to be working with EyeCOR even more down the road. So this is not a one-time shot, and I think we all can grow from now
yeah, yeah, I'll be lecturing at some meeting in person, so we can really interact even better. And then we are providing special pricing on EyeCOR for the United Eye Care doctors.
Thank you.
All right, Will, you can close.
Thank you, everybody, for being here tonight. We look forward to seeing you in November, and then hopefully when we get Bob in person.
Thank you.
Thank you.
Take care.